Right. Welcome, everyone. We're excited to have you here for the next installment of our CF newborn screening webinar series, Immunoreactive Trypsinogen Cutoffs. We're very excited to have three presenters today, Sciortino, Kendra Croak, and Stacey Martiniano, to share their experiences with IRT cutoffs in two different newborn screening programs. This is a part of a CF newborn screening webinar series that, with support from the Cystic Fibrosis Foundation, our team at CPHI has developed a series of webinars. You can find out more information about these webinars on our website through this QR code. I think this group is probably all familiar that CF newborn screening is a multi-step process, starting with the dried blood spot being collected shortly after birth and sent to the public health laboratory. The cystic fibrosis testing is done at the laboratory, both with immunoreactive trypsinogen and CFTR variant panel or sequencing. And then communication of the positive results happens to the primary care providers and the CF center, who then contact the families for follow-up. We're going to be focusing today on this middle part, the CF lab testing, specifically IRT, but our webinar series covers all three of these components. And I'd like to hand it to my colleague, Megan McGarry, to talk about the CF newborn screening guidelines.
I do not believe she's on the call yet.
She's not on the call yet. Okay, I will talk about the CF newborn screening guidelines. These guidelines were sponsored by the Cystic Fibrosis Foundation and were recently published, and the article is, the reference is listed here and below. Hopefully most of you have had a chance to review that guideline. If you haven't, we have a depiction here of the different components of the guideline with the specific recommendations highlighted in a darker color. So we have IRT cutoffs, recommendations related to CFTR panel testing and sequencing, and then communication at the bottom. Today we'll be focusing on recommendation 1, implementing a floating IRT threshold and how to calculate that, and then also the concept of implementing a very high IRT. So we'll be talking about IRT throughout the day. And that is these two here that are highlighted here, that the best practices for newborn screening programs to benefit all infants is first to choose a very high IRT, or to choose a floating cutoff, and then also to implement a very high IRT strategy. So with that, I would love to introduce my colleagues from the Colorado Newborn Screening Program and Children's Hospital Colorado, Dr. Stacey Martiniano and Kendra Croak, who will be describing their experience in Colorado. Stacey, I'll hand it to you.
Thanks, Marcy. And thank you to you and Yvonne for inviting Kendra and I to speak and share our experience. All right, so we're going to talk about some of the challenges we faced and then the steps we took to make improvements specifically within our IRT and in our program. And when I talk about our newborn screen program, I'm really talking about the program that covers all babies born in Colorado and Wyoming. And for our program, we are a 2-screen state, which uses an IRT DNA algorithm. So all babies born in our states have an initial blood spot within the first 24 to 48 hours of life in the nursery. And then all babies have a second newborn screen done between 8 to 14 days of life by the pediatrician that can screen for CF if needed, but then some other disorders as well. And so we have historically used a fixed IRT cutoff, and our level most recently was set at 60 nanograms per milliliter. And this was set in 2006. And what we did at the time was evaluate all our data and evaluated the different percentiles and chose 60 because that was at the 97th percentile at the time. Also more recently, within the last probably almost 10 years ago now, we did add an ultra high cutoff as well to really kind of expedite babies who more likely could have CF. So we set an ultra high cutoff of 140 nanograms per milliliter. And what that means is that we would do cfDNA automatically if that first newborn screen IRT was greater than 140. Also, this means that if we have 2 ultra-high IRTs, even if 0 variants were detected, those babies are still referred to our CF care center and a sweat test is performed. And at the time, and now currently still, we were using and are using a DNA panel, a Luminex 39 variant panel. So in 2021, our CF Center and the Newborn Screen Program team at the Colorado Department of Public Health and Environment did a deep dive into our data to evaluate if we could improve our IRT cutoffs. And this was primarily due to an increased rate of delayed and missed cases within our community. And so in total, we found 5 missed cases among 358,187 infants that were screened by our program between 2016 and 2020. And then we additionally found 3 more cases that were missed by the algorithm, if we had just used the algorithm blindly, I guess. But those babies did have meconium ileus, and those babies did have DNA performed and had prompt diagnoses done, but we still wanted to look into those babies as well and use their data in our analysis. And so this is a table just summarizing those 8 babies cases. And in that first column is the case number. Second column is if they were missed on the first or our second newborn screen. And you can see the majority were missed on the first newborn screen. If you look at the next column and really look at the IRT concentration, you can see the majority were in the high 50s for their IRT, so just below that fixed cutoff of 60. And as I mentioned, there were the 3 babies that had the meconium ileus here, here, and here. And despite not having an IRT that met the threshold, they did have meconium ileus, so DNA was performed, and those babies were still diagnosed within a few months of life, a few days of life. Those babies, and on average, the average age of diagnosis for these 8 babies was 3.7 months. So here's a plot of our 97th percentile IRT concentrations grouped by month from 2009, starting on the left, over to 2020. And the data themselves are hard to see, but hopefully you can see just over time, you can see a gradual decline in where that 97th percentile falls. And so, for example, I'll just tell you some numbers. When we initially set the 97th percentile, that was at an IRT of close to 60. And now, in more recent years, that 97th percentile is actually truly falling closer to 45 to 50. We did analyze the level of the IRT immunoassay. In blue was our initial assay. We switched to this new assay. Didn't see notable changes necessarily with the assay change. At a high level, we did not see changes in seasonal variation, but didn't do it, certainly not a deep dive into that data, but Stan will show some data related to that. Just kind of this gradual change over time that we really were not aware of because we weren't closely looking at the data. So when we thought about what could we do, we thought about primarily 2 big options. The first was, should we lower our fixed cutoff? The pros to this would be that this would be fairly easy to implement, regardless of the number of daily specimens we received. We felt like this would be fairly impervious to effects of high NICU levels or early draw days. The cons are that this really would not account for seasonal fluctuations or longitudinal changes over time. We would still need to be evaluating the data more closely. It would not account for any changes that might occur with different kits. Then we also thought about incorporating the floating cutoff. And so the pros to this would that this would really compensate for daily and also long-term shifts in assay performance. And ideally, not fall out and miss babies over time like we had in the past. The cons are that the daily floating cutoff requires at least 100 specimens for calculation. This is something that we do have, so we were able to account for this. Also, these could be prone to shifts with high levels seen from NICU or early drawn samples, and we wanted to accommodate for that as well. Also, we needed to have software and the ability to analyze the data, and that is something that we did have ability to do. And so ultimately, we felt like probably using both a floating cutoff, but then also a hard cutoff as a backup would allow us the flexibility of the floating cutoffs, but also offer a safety net if there were days where the assay was running high. And so we did data analysis. We considered the 95th, the 96th, and the 97th percentile floating cutoffs. We also wanted to lower that fixed cutoff from the 60 where we initially had it. And the things that we considered is we had cases that we knew we had missed. And so we wanted when any of our modeling to see how our changes would have impact those missed cases. And our goal was really to choose cutoffs that would match and match our data and catch either all or at least most of the babies we are seeing in our state. We also needed to account for how many more samples would be going to DNA and the costs associated with that. And then we also wanted to consider how our new cutoffs would increase the number of callouts that would need follow-up and the number of false positives. So I'm going to hand it over to Kendra now, who's going to go through some of the data that we were looking at as we were making our choices.
Thank you, Stacey. So over the next few slides, I'm going to go a little bit more in depth of what we went through in our evaluation process, some of the data that we looked at, and the way we did some estimates of how this would impact our testing day to day. And so we kind of did this step by step, first looking at each level of testing. The first level obviously being IRT testing. When you look at the floating cutoffs, sometimes it's a little easier to anticipate how many samples are going to come off as positive for a floating IRT cutoff, because it's going to be your top 4%. 4% of your samples are going to come off as positive. But if you're evaluating hard cutoffs, you might have to do that extra step to figure out exactly how many of those are going to come off as positive to use that number to help estimate things moving forward. So this is a table of just some of the hard cutoffs that we were considering that Stacey had mentioned. And then we have here at the top our 60 cutoff, which is what we had at the time, and then 55 and 50. And we evaluated data from 2016 to 2020 and looked at the percent of initial IRT tests that would have come in over that cutoff for that time period. And then we wanted to look at how this would estimate how this would actually look over the course of a year. So we picked 2020 as our sample year and based our numbers off of the samples that we ran for 2020 because we had that data available at the time. So when we applied those percentages, the 1.66% for 55, for example, to the number of specimens that we ran for 2020, 1,142% of them would come up over that cutoff. And then respectively 1,851 would come up over that cutoff for 50. And so from there, we're able to calculate the increase in retest. So when you do that test in the lab, you do that initial IRT, and then you confirm and duplicate, we're able to estimate the amount of retests that we would be doing. And so from there, we could extrapolate the additional burden on our IRT bench by adjusting these hard cutoffs. So we'd have an increase of 80% with the 55 and 192% for 50. Then we wanted to then see how that would spill over into our DNA testing. And so because we're a two-screen state, this has got a little added complexity to it because not all of our samples that are positive by IRT are going to be funneled into our DNA test. So we had to figure out about how many samples are being resolved with normal seconds, and a decent amount of them are. So again, we reviewed that data from 2016 to 2020, and we found that about 34% of our specimens that have been elevated IRT on that first end up being tested by DNA. And then we also did an estimate of our carrier rate because we figured that would give us an estimate of what our false positive rate would be. So we looked at it for the hard cutoffs that we were considering, and then also the percentile changes that we're considering. We looked at the number of samples that would be over the cutoff for each of those, and then from there, did 34% of those to figure out about how many samples would be run by DNA for each of those cutoffs. Obviously, there are dramatic increases in the number of DNA tests that would be running for this. That is one of the caveats of lowering the cutoffs, is some of that increased costs. And then also, obviously, you would have a slight increase in the estimated carrier call-out as well. So after we did those evaluations, as Stacey kind of mentioned, we decided to go ahead and pursue the 96th percentile floating cutoff with a fixed 50 cutoff as backup. These changes were implemented in August of 2021. I do want to mention that our second screen specimens, because we're a two-screen state, are not subject to that floating cutoff. They are only subject to the Heart 50, and that is in part because we don't run IRT on all of our second specimens, so I don't statistically have enough specimens run every day to set a floating cutoff for those second screen specimens. But with that being said, had we had this algorithm previously, 7 of the 8 missed cases would have been identified, which is great. And we chose a cutoff that was kind of in between some of the ones that we're evaluating, and so we felt like we weren't really overloading the system with false positives as well, but we're able to capture as many of those missed cases as we possibly could. We did maintain the 140 ultra high as a cutoff threshold on that first screen. As Stacey mentioned, it serves 2 purposes for us in Colorado. The first of which, if a baby has a specimen that comes in at 140 or above on that first specimen, they are funneled directly to DNA without waiting for that second specimen. So we decrease that time to diagnosis a little bit. And then also it kind of acts as a little bit of a safety net for some of the gaps we have in our second tier testing. Because if we have a baby that comes in with an ultra high value on that first screen, and then again on that second screen, even if they have 0 variants, they're reported out for sweat testing. We are considering reducing this to an ultra high of 100, with the caveat that babies under 100 or 1,600 grams or specimens are drawn before 24 hours of life would not be subject to that ultra high. By excluding those populations, we don't overload the system with a bunch of false positives because those early draws in NICU babies are stressed little kids who come in very high on IRT values. And it really increases the amount of samples going to DNA very little, but does capture a good amount of true positive samples that we have observed that come in between 100 and 140 that right now often have to wait for that second screen to come in. So. I do want to point out that this evaluation of our IRT cutoff was kind of part of a multi-pronged evaluation of our CF assay as a whole. And so there are other changes that we have been working on in tandem. One is that in the next several months, we'll be moving to NGS for CFTR testing for our DNA second tier assay. And then our CF Center has had a QI project that they've been working on to improve completion and timeliness of our sweat test. And these changes, together with the changes we've made to our IRT cutoffs, has made it so that our age of first encounter go from 39 days historically to 17 days. So it shows that, doing these changes and these evaluations really can have a positive impact on the process overall. I talked a lot about how we estimated the impact on our testing, and I wanted to just take a moment to take a brief look of how this actually looked in real life now that we're a few years out from this. So this table here has data from 2018 all the way to 2024 The changes were implemented in August of 2021. And we have the number of DNA tests for each year, the number of callouts, and the number of true positive cases. We do see, obviously, as expected, that we had an increase in DNA tests about in our expected range for most of those years, which was anticipated and fine. It was something that we decided that we were okay with in order to capture those missed cases. The other piece of this that I wanted to look at is where our cutoffs are currently sitting now that we've had this for a couple years, and it's kind of nice and interesting that our 96th percentile is holding right about that 50 range. So our hard cutoff and our floating cutoff coincide pretty well together at the moment. I'm relatively happy with how it's performing for our assay right now. It is also interesting to note, looking at this data, that it seems like we had a dip from the years of 2018 and 2020, which may have contributed to why we had some of those false negatives in the first place. I don't have a good reason to account for this, but it is a great argument for why implementing something like a floating cutoff can help you adjust for those assay changes over time and gives you built-in flexibility for your assay. So overall conclusions here is that IRT, while it is a sensitive biomarker for CF, it does have its limitation and needs a little bit of babysitting to be truly effective. And so we can increase the sensitivity and specificity of that through the IRT cutoff adjustments, as we've discussed here, and then also using those very high IRT strategies can help improve some of the sensitivity of IRT, but also be used to fill in potential gaps that you may have in other parts of your CF algorithm overall. And then the final point here, and I think this is probably the most important, and really it's kind of 2 points, is that it's really key to have a good relationship between your CF center and your Colorado newborn or your newborn screening program, your respective state, because having a knowledge of these missed cases really allowed us to do a deeper dive on this cutoff evaluation than if we had not had that, because it is really good to have, if you can, false negative data and then the ability to estimate or know your false positive data to really be able to finely tune where you should set that line for those cutoff evaluations. So having that information and being able to work together on that is incredibly valuable. And then a second piece of this is that the work is not done once you make a change, is that this requires continuous evaluation over time. You need to keep coming back to your cutoffs to make sure that they are still remaining true to where you want to your population and your testing as it currently stands, because it could change over time for reasons that you may not be able to fully explain. And with that, I'd like to say thank you for your time. Please reach out with any questions at the appropriate time whenever we're doing that in this presentation. I really appreciate you listening to our experience.
And Kendra, thank you so much. That was so clear and just very well laid out as to why you made the changes and how you made the changes. So thank you so very much. We will hold questions because there are a number of questions here. So we will hold them and put them at the end after Stan's presentation. So with that, I'd like to introduce Stan Sciortino, who will be presenting his experience in the California newborn screening program and changing the IRT cutoffs for seasonal variation. Stan, I'll hand it to you.
Hi, Stan Sciortino, formerly of CDPH and genetic screening program. Let's see. Whoops. Let's do this. It's a little lag. Disclaimer. So I am not representing California Department of Public Health today, and my conclusions do not represent the views of the Department of Public Health. However, we did publish this paper, Cystic Fibrosis Screening, Efficacy, and Seasonal Variation, last year, and you can read that, and it's available online. And that was approved by the state. And California has been using IRT DNA to screen for CF since 2007. And then to answer some questions that may come up, we only call out and inform the parents and physicians of a positive CF test when we have DNA information on the kid. And then, then there's subsequently to that, then physicians do sweat testing. So upon go live, we established a 1.6% IRT screen positive population percentile using a fixed cutoff. It's interesting that 1.6% came up in the last presentation. And this one was, when we came up with that, we knew nothing. We had some baby's breath data of the IRT, of kids who had CF going back like 10 years, and not a lot of that, about 1,000 positive kids with CF. And then we had population-based data that was flowing into this our system that we had as a pilot simultaneous to our ongoing screening. And we had a very limited period of time to evaluate that data and put it all together. And then the 1.6% was actually a negotiation, and I was in the room where it happened. Me and Marty Karazi, we went back and forth. Marty wanted higher, I wanted lower, but my target was really 1.6. It seemed to be a sweet spot where we're not going to, spend too much money on the DNA testing and reduce the number of carriers we'll identify and not really miss cases if possible. So in practice, the yearly percentile has been between 1.6 and 1.7%, and seasonal variation was not considered in 2007 at go live. California identifies about 1.6 CRMS cases to 1 CF cases. In contrast, other states with similar approaches, IRT screen they use the IRT screen positive cutoff of 4 to 5%, and the CRMS, the CF cases seem to be higher than 1.6. That may be changing over time. We will see. Okay, let's see. I'm pressing the wrong button. Come on. Here we go. So here's IRT is a sensitive measure, but here's the problem. So if you look at this IRT values by final CF diagnosis, and the first one is just population. These are CF. These are kids that are born, do not have CF, and the population mean is 24. But that right tail in California is huge. There are a lot, like that right tail would completely overwhelm the CF and CRMS and carrier cases for California. And you can see next one is CF is has a much higher mean, 160 versus 24, and is spread out all the way up to 200 or so. And the CRMS cases also spread out, but they are clearly overlapping with CF cases. And there is this unseen mountain of CRMS cases below our cutoffs that one would identify over the years. And carriers, again, there's a mountain of carriers below the mean. So we're trying to maximize those CF cases and minimize carriers with CRMS. Oops. So cystic fibrosis, newborn screening. This is all our steps, actually. IRT from 2007 to 2022. So we screened 7,400,000 kids. And as of 2022, we had about high IRT positive was about 1.66%. Familiar number, it's interesting. These were all sent to panel or sequencing. If after panel or sequencing, we had cases identified for 901, and we had high IRT missed CF cases of 44. And on the other end, low IRT negative amongst those 7 million there. The low IRT missed cases were 36 that we know of. And so the low IRT n equal 36 is 32.7% of the missed cases. You can see that below. And Here's our sensitivity and positive predictive value. Two views. If we look at just CF cases, the value for sensitivity is 92%. If we include the CRMS cases that we identify and follow up, that's 97%. And the specificity, of course, is really high, 99.999%. And the positive predictive value for CF was 34%, 1 in 3, but if you include CRMS, it's over 50%. So the seasonal model allowed examination of low IRT missed cases. So in 2007, we missed 2 CF cases due to low IRT during the summer months because of a new reagent kit that was initiated in May of that year. And the lab and our team didn't catch it. There was a new kit, and we always evaluate the new kit. We established a seasonal model using autoaggressive integrated moving averages, ARIMA, to set IRT cutoffs after reagent kit change. So this was applicable at any time of year, and we wanted to set it and forget it, maybe. What I mean by that is we have kits that last about 6 months from was once PerkinElmer. And so when we have a new kit, we want to just set the cutoff, fixed cutoff at that moment, and not have to worry about it the rest of that kit, the life of that kit. And I think we've achieved that. So we have since examined low IRT missed cases. That's what we're talking about today, and investigated why California has had success with a lower IRT screen positive rate to see if we can do better. So here's our daily mean IRT values over those years from 2007. You can see the daily mean changes quite a bit over time, and seems to be rising up over the years. And you can see the variability is not that high for each of those daily means. Now, if we look at the daily positive IRT percentiles, there's a great deal of variability, huge amount of variability over time. But look, it looks fairly flat because it's a percentile at that moment. Oops, let's see, 1, 2. And here's the results of our ARIMA model. And the thing to notice that the stable seasonality F tested above probably is far less than 0.00001. And moving seasonality F test is not significant. So it means that the seasonality is a standing wave. It doesn't move right or left. It's replicated every year, may go higher or lower, but it's not moving. And we have identifiable seasonality. Oh, I forgot I had animations. So here's the monthly seasonal factors. Mean IRT is in green, and the IRT positive percentage. And you can see above the 100%, which is 1.66%. You can see the mean, seasonal means the variability is low, but the seasonal positive percentile is high, changes quite a lot over the year. And you can see it's replicated every year. And those little dotted lines, if you're curious, are the kit changes. So these are the kits. Some of them last longer than others. Some are shorter. And then here's some results of our model. Here's the IRT positive results. And this is the adjusted percentiles that we would want to use at any given month if we were to use it. And the original, meaning this is the real data, and it moves up and down quite a bit. And let's see if this will work. And there in 2017, there was a dip in the summer because of that kit change. We didn't catch it quick enough. And notice we changed the IRT values from 62, if you look at top, 62, to 67 in 2013, and 67 went back down to 63. So you really have to watch for these changes if you're going to do fixed cutoffs. And here's the estimated IRT cutoffs in nanograms per milliliter over time. And you can see the red is, let's see, the gray is the estimated cutoffs, and they go up depending on what's going on with the kit. And these are the actual cutoffs, 62, 67, 63. And you can see in 2017, right when we changed to 63, there was a big dip, and we missed those 2 cases. And we definitely would have caught it had we been working using the model or even guesstimating what we should be doing at that time. And there weren't a lot of missed cases at the borderline, maybe 1 before and 1 after that period. Here we go. There's those 2. And then here's an odd one, seasonal percentage changes in IRT screen positive. So this is the standing wave, basically. And these are the months at the bottom. January's the percentiles move up. February starts coming down. May, June, July, August, they continue going downward and then head up towards December. And if you notice, those are, it's a little incomplete, but those are the missed cases that we found, and you can see they're all clustered to the right, July through December. There's a big clustering, and many of them are not that high. Most of them are low. And then here's the multivariate logistic regression, odds ratios, and confidence intervals. And you can see the effect. I looked at season and region. And the seasonal effect was quite positive. The p-value is 0.19 and meaningful. And you can see, if you look at number of missed cases, fall, summer, there are many in fall, summer, fewer in winter and spring. Percentage in fall and summer, 5.7%, 5.6%, much lower winter and spring. And then high odds ratios in those 2 months, those 2 periods. And then region is not significant. So this is one model, and the region didn't really have anything to do with our seasonality. When we ran this, we thought that some of the regions might be hotter or cooler, but it didn't really seem to make much of a difference. And we wanted to see, we do 1.6 to 1.7. We wanted to estimate daily and weekly floating cutoffs. And this is what we did here. And if you look, do I have animation? Maybe not. Nope. If you look, cutoff percentiles, if we were to do a daily cutoff, you can see the sweet spot for daily cutoffs would be 4% to 5%, where we would have fewer false positives, and we would have 15 or 19 true negatives and no new false negatives. And however, we would end up calling out 152% more samples for DNA testing. If we were to go to 5%, we would call out 276,000 more, or 212%. Now, if we were to do this, we'd probably do trailing weekly, and weekly we do better, and if you look at the gray, 3%, if you did 3%, we would miss no new false positive cases, and we would only call out 106,985 more cases, samples sent for DNA testing. So 3, so we would be 3 or 4% would probably be pretty good for us if we were to do that, but we are not doing that at this point. Now, we looked at the DNA, and that's in the paper, and low IRT missed cases. Here's the variance in California by the CFTR2 listing. And as you can see, not listed, there were a few, but most of them, you had either mutation 1 or mutation 2. Most of them were CF causing. And then there was a few, one not causing, and one or two were variable. And then CF causing, one case, I'll just describe one, was very interesting because there's a kid who had Del F508, 2 copies of Del F508, and the kid had normal IRT results, and but the kid had pancreatic problems, which the kid's pancreas was not pushing enough IRT into the bloodstream, and that's why the IRT was low. So let's see. And here's our California seasonal calculation table. And those are the months. So again, set it, forget it. If we are, if you look across the lines, the last column is IRT positive target, right? So in January, if we see a new kit in January, we'll target 1.8% positive proportion. And that 1.8% goes down to August, 1.4% in the summer. And we really don't have a problem with that. It works in the summer. And then it goes back up to 1.8% in December. And if we have a new kit in the summer, we could set it lower, and it will actually come up during the winter. And that is what we use. And it's a simple algorithm, actually. We can produce it. People can work with that one for California. And maybe other states who want to do this can think about this approach to seasonality. So here's our conclusion. In 2017, we missed 2 cases due to delayed recalculation of IRT cutoff. Since 2017, we have used seasonal adjustments to refine IRT cutoffs to minimize missed cases. And we missed low IRT cases. Missed low IRT CF cases are seen seasonally, most likely occur in the summer and fall, and show no unusual overall genetic profiles. And changing our approach to floating cutoffs will result in increasing the number sent for genetic testing. And if we were to do that, we expect to identify more CRMF cases if we move to the floating cutoffs. So using population-based data to calculate IRT cutoffs has been an efficient approach for CF screening in California, but we learned that we really have to pay attention to what's going on. And we're monitoring all our cutoffs at a monthly basis. So let's see. And I wanted to acknowledge the genetic disease screening program. Steve Graham helped with some of this analysis, and the California CF Special Care Centers, because they're the ones who identify the kids and also follow up over a 5-year period of time for us. And questions. I don't know if it's time for questions, but here's my little dolphin. I took this photograph and doctored it in Mexico a few years back.
Oh, love it. Thank you, Stan. And also thank you again to Kendra and Stacey for your wonderful presentations. And I love that both of you kind of ended with the fact that no matter what, no matter how you do this, you need to keep monitoring, right? It's that importance of monitoring, and the collaboration is really important. So I'm going to go back and start with the questions in the chat, but also if you have a question that you would like to ask out loud, please just raise your hand and we will also get to you that way. So Sarah from Oregon asked, what happens if no second screen is received in Colorado? Is the first just lost follow-up, or is there a fail-safe? And Stacey asked that the lab tracks and will just do the DNA on the first sample if the second sample is not received. And what's the time frame for that, Kendra? At what point do you run that?
We give them 2 weeks to get a second specimen in. And if we don't get that second specimen within 2 weeks, then the first sample is added to our DNA list. So.
Perfect. And related to that first screen, do you do DNA right away if the first screen has an IRT greater than 140 in the baby as well?
Yeah.
And, yeah.
Yep.
And that's been a key, like that was, I think, a genius move on your part together. I think this was part of that collaboration when you guys first came together saying, hey, let's do that. And that really, I think, helped to increase that age of first event.
Yeah.
Also for you, Colorado, how do you deal with specimens that are collected at less than 24 hours after birth?
This is actually kind of an evolving situation because I believe there's another question that kind of addresses this as well. So I'd like to just kind of take it all together, if I may. Someone asked, and I don't remember who, why we had so many DNA tests in the year 2024. That is because we have been encouraging our hospitals to do the NICU protocol that is recommended by CLSI, where babies that are going into NICU are drawn before they go into the NICU so that we can get results on them before they get medicated or treated or whatever. And then we get another specimen at 24 hours. So we have had a sudden influx of a lot of different samples drawn under 24 hours. For the most part, outside of the NICU, it's a relative rarity. So it's not as frequent as a problem, except now we're doing this NICU protocol. It started late 2023 with one hospital, and then in 2024, more of a hospital started taking it on. And so we had a jump up in our cases. And so we are actually currently still evolving our protocol for how to mitigate this because our hospitals are doing such a great job of getting that 24-hour specimen in. We are now not running DNA on those first specimens if they are ultra high and are drawn at less than 24 hours. If we have a second one already in-house, because they're coming right on top of each other most of the time. So when I make the list, a lot of times we already have the 1 hour and then 24-hour specimen. So if we have that second one in-house and it's under 140, then we don't add them to the list. We still have to deal with the fact that our system does still count that second specimen as an actual second and not technically still a first. And that is something that we are in the process of figuring out the best way to deal with. But that's what we're doing currently. Because it's been something that we've been figuring out the best way to manage over the course of the last 3-4 months.
Yeah.
As all of a sudden our DNA list popped up a lot, not longer than that. Sorry, what year is it? 2025, the last year.
I think it's 2025. It's hard to keep track. It's hard to keep track.
It's fine. I know what day it is.
Some days. I
So
think that
that's
also
kind of
answers Chris Dorley's question. And Chris, if you have additional questions to that, but she asked about what procedure you have in place for NICU babies. So I think you addressed that. Chris, if you have additional questions, please hop in.
No, I don't. Thank you.
Perfect. And then there's a question of, do you have any discrepancy rules for initial IRT and the retest IRT on the first sample? So if the initial IRT is above the cutoff, but the retests are below the cutoff, which result do you take action on? Or do you do the IRT mean? And also the retests included in the floating mean calculation.
Those are great questions. And so effectively the way I have our algorithm set up now is that if it comes up and flags above our cutoff on the initial screen, it still goes out with a flag on the retest, regardless of what the retest values are. But we do have like a couple of different categories of those flags. So we have, hey, this specimen came in above 50, which is a little bit higher risk. And then we have, hey, this is in the top 4%, which it means that it didn't come back in over that 50 or in, we don't, it basically means if it didn't come in, the retest didn't come in over that 50. The retests are not accounted for in our calculation of the daily floating cutoff, only the initials do, because if we add those retests in, we're kind of shifting that floating average a little bit higher again, which is not really what we like to do. And so we have it set so that they all flag once they have that initial over cutoff. It's just a matter of the risk of the flag that's determined by that retest value.
And then related to that, do you use the IRT values from less than 24 hours to calculate the daily cutoff?
We do, which is one of the reasons we had the hard 50 as well. We currently don't have it set up in our system to like separate those out necessarily. That is an interesting idea and maybe one that we could look into moving forward as we look into ways to deal with the NICU protocol and its impact on the CF bench. But for the moment, the 50 hard cutoff has kind of been our answer to that, because at least make sure that even if we have a lot of things shifted high for those babies that are early draws, we are at least capturing everything 50 and above.
Perfect. I think I've caught all of the questions from the chat. Are there other questions that you might have for either the Colorado team or for Stan? All right, hearing none, we will make sure we send out the links to their papers as well, so you can have those access to those papers in our follow-up from the meeting with the recording. I wanted to, before we sign off today, if you have more questions, here's Joe has another question. What is your opinion of a two-screen state with IRT DNA model using the fixed and floating cutoff switch to IRT DNA model to reduce the number of CF DNA? Ooh. So calling for that second specimen, is that what you're saying, Joe? Yeah. So doing a floating first, a fixed second, calling for a second specimen. I guess you have the second specimen. So the,
if I understand the question correctly, I'm a little biased because that's what we do, and I think it's effective. It does. Part of the reason I think it's effective is that even though there's a risk there that you are potentially extending the time to diagnosis for some of those babies, we are also reducing the amount of false positives we're putting out into the system, which has also been a problem for us on the CF bench, is that sometimes we get so many flags for IRTs out there that some of the providers don't always take them as seriously as we need them to. And so we do need them to still pay attention to those. And we also don't want to like overwhelm the families or CF centers with sweat tests, right? And so for us, I think that it's a really good algorithm to balance those two components of newborn screening, of making sure we're getting these kids to diagnosis and the treatment they need in a timely manner, while not overloading every other part of the system with a lot of potential false positives or a lot of information that they're not ready for. But again, I'm biased.
yeah, and I think having that ultra high IRT, the very high IRT, that you send those immediately to DNA, I think has been really very helpful. And then we have a question for you, Stan. You see that question?
Oh boy.
Is California thinking about lowering their percent cutoff?
Lower, well, I've made recommendations that go towards 1.7%, just a little bit, call out a few more, and I think that is good enough. We just don't see so many at that boundary. Well, missed cases are not happening at the boundary, but some of them are, you know. And I can't speak for the state at this point, but we were going, when I left, towards doing next gen testing, which you know may not change the results all that much, but it will shorten the period of time that we have if kids only identified with one variant on the panel. And we did change from a 32 variant panel to 72 or 5, however you want to count it, panel a few years back. And it didn't make all that much difference, tiny bit of difference, you know. And we added a whole bunch of variants that we knew were unusual and occurred in our racially diverse population at that time.
Wayne talked about that, right? Where they had a 39 variant panel and the missed cases were all F508 del mutations. So that's interesting.
Hmm.
Yeah, and that's, I think he was commenting, you're right, Giovanna, is commenting on Stacey's data of the most of the variants or most of the missed cases had a 508 del.
Yep.
So they wouldn't have been missed. Yeah.
I think there's a list in the paper. So if you want to look up I think I put a list in. I was always trying to push data out when I could. So,
All right.
thanks.
I just want to very quickly go through some other resources. The Cystic Fibrosis Foundation has helped to sponsor some genetic resource centers. For those of you who are interested in sequencing, expanding your panels to include the CFTR2 known disease-causing variants, and yet might not yet have the resources in-house to be able to do that. Both the Wisconsin State Laboratory of Hygiene and the newborn screening program at the Wadsworth Center in New York are offering resources to help you do those, that you can do send outs, and they will run those panels for you. And they will do panel-based testing. They're reporting the VVCCs if you are interested in that. And they also do CFTR gene sequencing analysis or reanalysis. So if you're interested in that and would like that help, they can also do technical assistance if you're interested in wanting to do next-gen sequencing in-house and you aren't quite ready yet, or you need that extra help, they can provide that. So if you'd like additional information on that, I would encourage you to visit our website, our CPHI website, which I'll show in just a minute. We also have another webinar in this webinar series that will be next Thursday at the same time on genetic variants and reporting after sequencing. So, you know, if you're doing sequencing, what are you going to report? Are you going to report one variant infants as carriers? Are you going to report them as normal or as abnormal and get a sweat test? How are you going to do that? And we have the expertise of Megan McGarry, Karen Rary, and Deanna Green to help us think through that. And you can register through this QR code or through our website. And we'll also send these links out in our email. And then finally, if you're interested in joining some of our CF newborn screening collaboratives, this QR code also works for that. We meet every other month. And these groups talk about specific issues related to CF newborn screening that states might want to be tackling. So with that, if you have any questions, this is our lead team on these webinars. Please feel free to reach out to us. We would love to chat with you and look forward to seeing you on our next webinar. Thank you so much, everyone.